Okay, so good afternoon. Thank you all for joining our pre-receipt webinar for our Caring for Outpatients After Acute Kidney Injury, the AKI Research Consortium. From NIDDK today, we have Dr. Ketchum, Dr. Paul Kimmel, Dr. Starr. I'm not sure if you have anybody else. Introduce yourself if you're on. That's it.
I am Dan Batley from Northwestern.
I think you can all see my screen, hopefully. So what I'll do first is I'll go through some slides that describe the RFA. I have a few questions at the end that people have sent me, and then I'll open it up for questions. You can either write them on the chat, or I guess depending how many participants we have, we can, you can just ask the questions. But hopefully I'll cover a lot of the potential questions here. Please feel free to ask at the end when I open it up. So I don't know if you can see all that. So the funding opportunity, purpose, and description. This is a Caring for Outpatients After Acute Kidney Injury, COPE-AKI. It's two RFAs. One is for clinical centers and one is for a scientific data and research center. This consortium is going to be composed of 3 to 4 clinical centers and 1 scientific and data research center that will develop interventions that aim to reduce morbidity and mortality compared with usual care in patients after hospitalizations with stage 2 and stage 3 AKI. Both clinical outcomes and patient-centered outcomes should be assessed. We encourage those both to be considered. The FOA is not intended to test novel drug therapies. So phase 1 to 3 drug studies are not responsive to this FOA. Delayed onset studies that are data gathering in clinical study and another aim are also not responsive. So what do we know? We know that acute kidney injury is associated with high morbidity, including increased chronic kidney disease, end-stage kidney disease, and cardiovascular disease, as well as mortality. We know that severity, duration, and frequency of episodes of AKI, as well as age, pre-existing CKD, and other comorbidities are associated with greater risks of CKD progression and death after a So there's many more unknowns than knowns. There is limited evidence to inform recommendations for processes of care or therapeutic interventions that target progression of kidney disease and its associated morbidity and mortality in adult stage 2 to 3 AKI survivors, which is the population that we're focusing on in this RFA. Can a medical intervention in AKI survivors, such as a nephrology clinic follow-up, education, clinical care, therapy with available treatments, can any of these potentially improve outcomes in this population? What are potential designs for a study to follow up post-hospitalization AKI patients? In whom or when might intervention be effective? What are possible primary outcomes that might respond to an intervention? Adequate power, and the number of available patients that would meet inclusion-exclusion criteria. So in the RFA, we described various gaps in knowledge. For example, important gaps in knowledge and care in AKI survivors that could be addressed include, but are not limited to, management of risk factors for development of chronic kidney disease, end-stage kidney disease, and cardiovascular complications, blood pressure goals, the fragmentation and heterogeneity of care, poor communication among providers, and other socioeconomic barriers are all gaps that we could look at. Interventions might include, and again, not limited to, primary care or nephrology outpatient follow-up, coordination of care using bundled processes of care, the use of telemedicine, social media, other digital mobile platforms for implementation and evaluation of processes of care, pharmacologic or non-pharmacologic methods to prevent recurrent AKI, and targeting of established pathways of progression, in CKD, as well as physical and psychological rehabilitation in these patients. Some outcomes to consider include, again, not limited to, recurrent AKI hospitalization, all-cause hospitalizations, composite endpoints that includes these, major adverse kidney events, CHF, etc. And there's, of course, patient-centered outcomes that we would like to consider, and these, again, include, not limited to, patients' perceptions of health-related quality of life and functional status, patients' knowledge, symptom control, psychosocial status, and proposed trials that could and in addition to all these, proposed trials could include the study of patients with COVID-related AKI. So regarding the structure of the consortium, the COPE-AKI consortium structure, it will, this FOA will establish 3 to 4 clinical centers that will work collaboratively with a scientific and data research center in a consortium. The studies proposed by the successful applicants will be the starting point for discussions regarding the research to be undertaken by the consortium. And so it's important to emphasize that the final study protocol will be designed by the clinical centers and the SDRC, PIs, and approved by the steering committee and the DSMB and NIDDK. It is envisioned that a successful applicant for a clinical center will have a large population of patients with AKI that can be identified and followed as outpatients after hospitalization. We would really like for these patients to be recruited before discharge, so identified and recruited during their AKI hospitalization and prior to discharge would be ideal. The clinical center and SDRC investigators will work collaboratively on the design, the planning, execution, and analysis of the intervention. Important to note, and again, all this information is in the RFA, I'm just reviewing it for everyone. But I do want to highlight that each clinical center will be required to enroll and follow between 300 to 500 patients in the study. And each clinical center will submit a plan for screening hospitalized AKI patients to identify patients being discharged and a proposed outpatient intervention. And the total number of patients that we would like for the study is in the 1,200 to 1,500 range, as we think this is a sample size that we will need to be able to have a significant clinically relevant outcome to be powered appropriately. The SDRC investigators, including the biostatisticians, will work with the clinical center investigators to develop the scientific design of the study. This is an important point, again. The consortium PIs will have the primary responsibility for ensuring that the design of the study, including primary outcome, is scientifically sound, comprehensive, with sufficient statistical power to study the primary outcomes. As I was saying, the end with our frequently asked questions, a clinical center can propose satellite hospital sites and other sites, either locally or out of state, to work together under its direction to fulfill the recruitment requirements. There will be a steering committee that will serve as a governing body for the consortium. The steering committee will be composed of the SDRC and clinical center PIs, other key investigators, and the NIDDK project scientists, as well as patient participant representatives. The steering committee responsibilities will be providing input on and approval of all studies developed by the consortium. There will also be an executive committee comprised of the steering committee chair, the SDRC PIs, and the project scientist. And the NIDDK project scientists will assist the steering committee in the development of the consortium study protocols, will monitor the progress of the projects and the functioning of all consortium activities, and will assist investigators in the analysis and interpretation of the data, etc. Again, the final study protocol will be designed by the clinical centers and the SDRC PIs and approved by the steering committee, followed by the DSMB and the NIDDK. The DSMB will be appointed by the NIDDK at the beginning of the funding period to provide input on design of studies prior to implementation. It's important that both the clinical centers and the SDRC identify 2 representatives of the patient population to be studied to serve on a community advisory council. And we will be asking the awardees to meet to finalize the consortium study protocols. And both the clinical center and SDRC awardees should be prepared to participate in conference calls immediately after funding and plan to attend a steering committee meeting, either virtually or in Bethesda, depending what the COVID situation is at the time. So funds available for the clinical centers, the funds of the NIDDK intends to commit $2 million in fiscal year 2021 to fund up to 4 awards. Application budgets are limited to $500,000 per year in direct costs. The way the guide is written, it's written just in the first year, but you can assume that this will be the same every year for a maximum project period of 5 years. For the SDRC, NIDDK intends to commit up to $750,000 in fiscal year 2021 to fund 1 award. Application budgets are limited to $500,000 in direct costs per year, maximum 5 years. So now I'll go through a few questions that I received through email. The first one is the NIDDK CKD e-care plan developed, and will it be available to be utilized in the study? How do we access it? And we have Jenna Norton with us here, and she will answer this question.
Sure. Can you hear me okay?
Yes.
Okay, great. So basically, the CKD e-care plan work has been combined in partnership with our colleagues over at the Agency for Healthcare Research and Quality to a multiple chronic conditions e-care plan. So we've expanded our initial set of CKD specific data elements to include some additional chronic conditions, specifically cardiovascular diseases, chronic pain, and type 2 diabetes. And we have a working draft of an HL7 implementation guide, as well as a SMART on Fire clinician-facing care plan that will be tested this September at the HL7 Connect-a-thon. We'll then take it to real-world testing, and then followed by some revisions based on what we learn from both Connect-a-thon and real-world testing. To make a long story short, that's sort of a broad overview of where we are with the project. You know, it depends a little bit on sort of how quickly the protocol development moves for this, but I think that it's likely that there would be at least some version of the application that could potentially be adapted for this study if that is of interest. And my email is just jenna.norton, jenna.norton@nih.gov, and I'm happy to answer more specific questions, you know, regarding implementation of the eCare application and implementation guide. And I can also send out a link, or I'll put it in the chat, to the overview of the project for a little more detail.
So just in a practical basis, in preparing your applications, you might want to endorse, if the study uses the eCare plan, that you are interested in participating in that, because that's going to be something that's going to be key from NIDDK. So that's sort of one of the conditions of consortial participation. Is that correct, Yvonne and Jenna? Have I put it correctly here for the investigators?
Yeah.
This is Rob. I was just softening a little bit that if you want to use the e-care plan, but the e-care plan will not be a collaborator with you.
So for the next question, does the SDRC have to propose a specific clinical trial design in the application? And the answer to that is yes. We would like the SDRC to propose a specific trial design for the reviewers to evaluate. Do you want to add anything to that, Paul?
No, I think that's clear. Every application is going to have to propose a clinical trial design, and as Yvonne pointed out early in the presentation, the final design will be developed consortially when everybody gets together in 2021 after the consortium is formed.
Next question, the RFA states the first year budget for direct cost is 500,000. Is this the annual amount for the SDRC, or does it increase in the subsequent years, and if so, to what amount? This is the expected annual amount for subsequent years. Unless Dr. Starr says differently, it stays the same. So will the NIDDK be receptive to a single center applying as both a DCC site and a clinical site? Is there any concern about this, assuming the PIs would be different for each application? That's important that the PIs are different and there's no budgetary or effort overlap. Otherwise, it's technically allowed. And I don't add any caveat to that. On a similar note, can you mute yourselves if you're not speaking? So, may investigators listed on clinical center proposals also have a role in SDRC? Again, as long as there's no budgetary or effort overlap, this would be allowed. The RFA allows for multiple PIs. Will the NIDDK be receptive to a clinical site submission recruiting from multiple sites? Yes, multiple local or out-of-state sites are allowed. This is my telephone number and my email. These are the links to the RFAs, which I'm sure you have because I've emailed you many times. And that's the end of my presentation. And now we'll open it up for questions.
And probably, Yvonne, for everybody to get an equitable chance to answer questions, would you suggest using the chat or would you suggest verbal questions?
Let's see, we have 49 applicants. I would suggest using if you put it in the chat, I could read it and answer. That would be ideal. It'd be hard to manage 49 people speaking at the same time.
And of course, if you don't have any questions, we can have a very short meeting.
So the deadline is November 4th, 2020. Is the final protocol anticipated to address a single intervention or possibly multiple interventions? Paul, you want to take that one?
Sure. I think that you're going to have to consider issues of power, and you're going to have to consider generalizability. You have to put yourself in the viewpoint of the reviewers. So it's certainly within your purview to propose any kinds of trials that you like, but you don't want to be perceived as being unfocused. So that's a very important choice, how you present your clinical design. I would say in most of the NIDDK consortia, people have only presented one design, and that's difficult enough to get the design that can be generalizable and can be effective.
This is Rob. I just want to add one thing that I agree completely with what Yvonne and Paul said, and that is to also take into account the size of this consortia. Don't propose something that's going to take 150,000 patients. It has to be somehow titrated to the size of the.
The next question is, how should the SDRC budget in relation to the proposed project? I don't know, do you want to go ahead and speak and ask and expand on your question, Dr.?
Yeah, I can do that. This is Paul Ababa from the University of Pittsburgh. Thanks. So obviously you mentioned the SDRC application needs to, in addition to the other CC applications, needs to have a proposed interventional study, obviously as part of the proposal. But in terms of the budget, should we be focusing our budget on that proposed project, especially given that, like you said, when the consortium comes together, the specifics of whatever protocol would be put in place would be done later on. So should our budget be tied into what we're proposing, or should it be more reflective of the expertise that the SDRC is bringing to the table?
Yvonne, if you don't mind, I'll be happy to take a crack at that. Your budget should be pitched to the SDRC work, which is described in the RFA. So the SDRC is not going to be recruiting patients. It's going to be coordinating data flow, analysis, the meetings. So it should be like a typical SDRC budget. And you know, as Dr. Starr said, considering we're anticipating 300 to 500 patients recruited from 3 to 4 centers, what the scope of the study is, and you know a little bit about the proposed parameters. So I would focus on the kind of typical work that an SDRC does in coordinating a large clinical trial. Does that answer your question?
It does. Thank you very much.
Sure.
Okay, so another budget question, Paul. Should clinical sites budget biomarker and or other outcome studies, for example, EKGs, echo, or is this for SDRC?
I think one could, but those final decisions are often made on a consortial basis. So the SDRC should also be budgeting for lab tests, but I think it would be good for the clinical sites to outline what they thought the cost of the tests would be, because as was previously stated, every site is going to present a different trial.
What is the expectation in terms of preliminary feasibility data? So we do expect centers that have expertise and expertise in the infrastructure and the patient population applicable to this RFA. So, you know, if you have a preliminary or feasibility data showing that you could run a clinical trial in AKI patients, that would be, I think, important. Paul, do you want to add to that?
No, I think you're right on.
Are kidney transplant patients?
This is Rob. Let me just add a little bit. This is not a drug study, so we're not expecting anybody to have animal data from the drug work. We also completely understand that AKI is understudied, and there's not a lot of existing clinical trial out there to base what this study would be. So I think we understand that quite well, and that's why we're doing.
Well, to be a little more explicit about that, what your job is in the application is to convince the reviewers that you can recruit the number of patients that are necessary, that you can retain them, and that you can participate consortially. So the feasibility of your proposal is critical.
It's the feasibility of executing. I think that's what we're all saying.
Next question asked is, are kidney transplant patients included? We had not considered that. Paul, do you want to take a stab at that?
I'll be happy to do that. I would think that basically the reviewers are going to be brought together by the review officer, and they're going to be told that this is a large clinical study looking for generalizable populations, something that will be, useful to the broader community. And since it wasn't a transplant study, I would suggest that that would introduce heterogeneity that would not be welcome at the review stage. But you can interpret the RFA any way you want. My interpretation of the RFA is that I would be looking for patients who had AKI after hospitalization rather than a more specialized group.
This is Rob. Let me just add to that a immediate post-transplant study where you're adjusting immunotherapy and stuff like that is really NIAID. That's really not the intent of this, nor in the mission of NIDDK. So I would certainly not propose a study that's 100%.
Next question. For clinical site applications, including different institutions, do we need single PI or multiple PI applications? So you can have a multiple PI application, that's encouraged. It could be a single PI. That's up to you.
It all depends on your justification. If you're going to do a multiple PI plan, it should be well justified. A single PI for a site is perfectly acceptable.
That was the last question on the chat. I don't know if somebody else wants to ask a question. This is your time. Rob, did you want to add anything?
Oh, Georgia has a question with
there we go.
indentations and bullets.
Oh, wow. Okay. Okay. SDRC, oops. 1 second. SDRC is to cover the cost of transport of the biological samples from the CCs to the SDRC repository. Will the government FedEx rate be available to the SDRC as it was for AKI? I don't know the answer to that question. Maybe
In general, Georgia, we try to get the government rate for every study. So this would be the same kind of thing. And covering the course of transport of biosamples to the central repository, that's usually a data coordinating center function. Who covers the cost of sample collection and shipping supplies? That will have to be negotiated at the time the consortium starts, unless stipulated in the RFA.
it's not, but probably SDRC, but yeah, I don't think it's specified. It's not specified to that detail.
The SDRC is obviously going to have to cover all consortial costs. So, you know, if there's shipping to central labs and things like that, you know, generally that's a central function.
Okay, next question. When would we be notified of a successful application? So this will be reviewed February, March study council. So I'm guessing around May, after May council. Can you distribute the slides you showed? This entire presentation is being recorded, and both the slides and the recording will be available on the NIDDK website in approximately 3 weeks. And by the way, all of this information is in the RFA. I literally took it from the RFA and put it on the slides. So there's nothing more in here that you don't already have. And of course, please send me your questions. I'm available by email as well as phone. And I try and get back to you as soon as possible.
This is Rob. If you are serious about applying, I really suggest that you talk individually to Yvonne and also to Paul to just go over what you want to do, and they will help you make sure that you're in rough frame the RFA for, and if you have and answer all your questions. The first is this webinar to take a comment. Deal with it.
The other thing I would point out for people who are not familiar with the kidney division's consortial structures, might be good to reach out to colleagues who have participated, because although this is fairly typical of one of the consortia that we sponsor, if you're not familiar with it, it often helps to get some feedback from someone who is or has experience. And of course, as Rob said, Yvonne and I would be very pleased to discuss issues if you have them.
And the other thing that Paul and Yvonne will do is if you send them about a one-page summary of what they'll help you. We cannot look at anything longer than that, but a one-page justification page we'd be more than happy to look at and comment on and give you as many helpful suggestions.
Okay, so if there are no more questions, we can end this session. And again, please email me, call me with any questions, a specific AIMS page, whatever you would like, and we can discuss further.
All right. Good luck, everyone.
Thank you.
Good luck,
Thank you.
and thank you, everyone, and stay
Thank you.
healthy and stay sane. Bye-bye.
Bye.